Welcome everyone to our monthly implementation science seminar series. Today, I'm really thrilled to have Dr. Timothy Hunt with us today, who's going to be talking about piloting the TechMPower protocol, advancing HIV and SUD care and service delivery for people involved in the criminal legal system. And I'm excited too because this is a hybrid two-stepped wedge trial that's being implemented in both in 6 New York and New Jersey county jails to look at a bundle of implementation strategies. And Tim and I have been talking for some time about some of the practical challenges of some of the aspects of this study, including the IRB protocol. So he's going to be sharing that with us. A little bit about Dr. Hunt. So he's an associate research scientist at Columbia School of Social Work. He's also the associate director of the Social Intervention Group and the Global Health Research Center of Central Asia, as well as Columbia Center for Healing of Opioid and Other Substance Use Disorders. He has provided trauma-informed family therapy, substance abuse treatment, and chronic disease prevention and care for over 34 years across both global and domestic settings. And much of his work has been done really globally. He's worked across 14 countries. So I am really thrilled to have Tim here and welcome. And I'll monitor the chat if people have questions, but we'll leave some time at the end for questions. So thanks, Tim. Hand it over.
Thank you so much, Rachel. It's good to see some familiar faces, and we're going to introduce some of our team that's on the call as well today. Really hoping the presentation today is useful, practical. As you heard Rachel say, we're going to talk a little bit about some early lessons learned as we pilot this particular protocol in preparation for a larger study. And thank you so much, Rachel, for your support. I'm going to talk a little bit about some of the challenges of IRB approval when working with people who are detained in prisons or jails, and how that is a unique aspect of research. Just to start out with, we want to acknowledge, first of all, people who have experienced incarceration or engagement in the criminal legal system and some of the trauma that may come along with that, people who use substances in recovery or in active use, and also people living with HIV for their experiences, their shared lessons learned. We appreciate our investigative team, our multiple principal investigators and team on project team. You'll see some of those today in just a moment. And our community partners in this type of research, which are really critical, especially developing partnerships and champions to make the work really feasible. And thank you to our funder at NIDA for this particular funding and for also funding that we'll reference on the HEAL community study. This is our co-investigators, our 3 multiple principal investigators, Dr. Fry and Dr. El Basel, and our co-investigators as well at the School of Social Work, as well as in Pennsylvania, Miami, and in San Francisco, and our colleague from Einstein as well, some of you may be familiar with. We have a great team with our project director, Don Gruss, and our community engagement specialist, James David and Mark Page as well, and Drews, who's helping us out with our data. Just to put some background, why are we doing this work in general? And just to be reminded that this is about co-occurring disorders. We're really focused in this particular project on HIV prevention and neutral status. That means people living with HIV, increasing access to treatment, but also increasing prevention of HIV, co-occurring mental health issues, but for those who are using substances. And as you can see, we've made a lot of progress when it comes to HIV prevention. But again, in 2022, almost 38,000 new infections with a 5% increase across the U.S. When it comes to substance use disorder, look, 1 in 10 people, 20 million people living with some form of substance use disorder, most undiagnosed. And when it comes to mental health, 1 in 5 people who experience some form of serious mental illness. And then put this in context of incarceration, with 65% of all U.S. people incarcerated have some substance use issues. Some would say up to 80% who are incarcerated may be experiencing substance use disorder. And when it comes to HIV, we don't have a lot of particular research, but in prisons we have some indicator of about over 1% of people living in prisons living with HIV. That's 3 times higher than the general population. And the amount of money we're spending on incarceration now, we need to mitigate some of the issues that are in the trauma experience of those who have been incarcerated or coming in contact with the criminal legal system. And why is this a particular priority when it comes to HIV prevention? Look, the prevalence of, I guess we just said, the prevalence is higher for those who are in state prisons, especially there are risks upon release from incarceration when it comes to substance use combination risk, when it comes to overdose, HIV risk behaviors, and both opportunities to introduce people to the mechanisms of change as well as treatment options. Combining things around HIV with hepatitis C, other sexually transmitted infections really needs to be looked at and combined. And as we know, there has been certainly stigma has inhibited people seeking treatment, especially even stigma toward incarceration, stigma toward HIV and substance use disorder can cause people to avoid providers altogether. And then distrust in this system is a major issue when it comes to engaging people who may need care, which is why we need this research, and this is why we need more examination of strategies to enhance evidence-based practices in the criminal legal system. Of course, the CDC pillars, which we are all highlighting here in this particular study, are diagnosing more people with HIV, getting them into treatment immediately, so rapid access to antiretrovirals, but also prevention strategies, biomedical strategies, including pre-exposure prophylaxis, and also engaging mechanisms of harm reduction, such as syringe programs in this process for co-located programs is really, really important. Responding quickly to outbreaks is really critical. And so we have the strategies, we have HIV prevention strategies that are even rolling out next year with more injectable approaches to PrEP, to ART. Many more mechanisms and biomedical strategies are being introduced. The actual uptake of these strategies is something we need to keep looking at, especially when it comes to an equitable lens. As you see here, there has been a slow uptake among Black and Latino when it comes to PrEP, and especially also among women, among Black women. And we have a lot of work to do to address the inequities here, both to access and to address the barriers to uptake of this prevention strategy. When it comes to actual people incarcerated, there's a study here of 371 jails in which only 7% of those offered opt-out HIV testing, 25 offered screening with testing, and 40 of these particular jails offered no screening or testing. So when it comes to PrEP, only 9% offered PrEP, and often issues around who will pay for these medications comes up, especially when we don't have a Medicaid waiver for those who are incarcerated. Their Medicaid has been turned off. We know in California they're now implementing the waivered program where people can access health care paid for by Medicaid. New York is next in line. We hope that will be introduced in 2025. Another combination issue we certainly have been looking at, especially through the Healing Community Study, looking at overdose prevention, is people are at high risk when it comes to overdose within 2 weeks post incarceration. So it's been about getting people on treatment, especially methadone, buprenorphine for opioid use disorder, making sure they have access while they are incarcerated, and then linking them to care post incarceration. We know that we see better outcomes when people are in care when it comes to reducing recidivism, reducing behaviors that may spread HIV or other sexually transmitted infections. In New York, we have been very progressive, introducing legislation in 2023 that required all forms of medication for opioid use disorder to be offered in prisons and jails. We have been a part of the rollout of that and supporting the mechanisms and strategies to sustain that type of approach. And we are building on those strategies now when it comes to HIV integration in local county jails. As part of the Healing Community Study, which we are in the final year of this study, launched in 2019, a NIDA and SAMHSA funded initiative, the largest community-engaged intervention study looking at substance use disorder and overdose prevention in 4 states and 67 communities. Here in New York, we had 16 counties we engaged, which include county sheriffs and jails as part of the strategy. Our multiple PI on this study, TechMPower, is also the PI for HEAL, Dr. Nabila El Basel. So we are building on the work of community engagement that included the carceral system. You see here in our coalitions where we've built 16 coalitions in New York State. Participation from the criminal legal system includes courts, government involvement, probation, parole, but also sheriffs and police, including those captains and administrators of jails as well. As part of that, we did action plans that include evidence-based intervention, and you see here how many of these evidence-based strategies included the criminal legal system: overdose prevention with naloxone, medication for opioid use disorder, and safer prescribing when it comes to opioid pain management. Why do I even bring this up? We're building on that today, that kind of integrated approach in these particular jails, and the wave of integration where we're building the protocols and mechanisms to offer HIV testing and prevention and care. We're also building on partnerships here in our pilot site, which is one of our HEAL counties, had an integrated approach, as you see here, for prevention and linkage to care, which included law enforcement. It includes peers with social workers. It has continued to be refunded, and it has been a national example of an integrated approach to help with law enforcement and community together. So this is our partner in the pilot, and where you see they link people to care from different mechanisms, from hotlines, from 911 calls, but also directly from the jail facility itself, linking them to both the level of care they need, but also medications for opioid use disorder. As part of this initiative, TechMPower, we are part of a larger project at NIDA called Connect, which is their new approach to collaboration, to data sharing, to lessons learned, to data integration and collaboration. So we are part of this, which includes these particular 7 studies. You'll see in the center that we are a part of 3 studies that are looking at carceral settings versus a community-based criminal legal engagement setting or a police intervention here. You probably know many of these investigators here. So we do meet as part of our requirement of the funding with them regularly, as well as data sharing and integration. TechMPower, so what are we doing here? We're really trying to test in a hybrid type 2 trial, right? Type 2, where we're looking at both effectiveness and implementation. In a stepped wedge trial, we're trying to look at what is the effect of the bundled strategies of implementation strategies on the uptake and an advancement of evidence-based practices. And then again, what are those direct impacts on clinical outcomes? We'll be doing this in 2 phases. An R61, which is a pilot phase, which we're in the middle of it right now, and I'm talking about today's protocol, which is to inform the stepped wedge R33, which is a trial, a randomized cluster trial, stepped wedge, hybrid type 2 in 6 jails, 4 in New York and 2 in New Jersey. So what is the question here again? What will be the impact or effect of this bundled strategies on the uptake of evidence-based practices that already are being used in jails, but we hope will be enhanced, where fidelity will be enhanced, that effectiveness will be enhanced, so that we will see it in our clinical outcomes, which are primarily, as you see, knowledge around HIV, knowledge of SUD, substance use disorder, but also then linkage to biomedical strategies to both treatment as well as prevention. We are also going to be looking at overdose prevention as well. So our aims for the pilot are about proof of concept, feasibility, and believe me, the team on the call today could share lots of lessons around the challenges of working in this type of setting, where the timeline must allow for engagement on so many different levels and negotiation of scopes of work, negotiating safety, negotiating priorities of the actual facility as we also prioritize health of those who are detained. So we're going to be use mixed methods, qualitative interviews, as well as surveys at 2 time points, uh, looking at people detained, a sample of 50, as well as staff and administrators, a sample of 20, to capture uh, from that what are some of the factors that impact adoption, feasibility of the strategies we're implementing, as well as the evidence-based practices we are supporting. We'll also be looking at costing and developing our tools for costing for the R33. We're using a mapping strategy, a 6-step mapping of implementation strategies so that we see what needs to be tailored in each site as we roll out in our 6 sites in the next phase of the study. This is really critical. It can be labor intensive as we see that it's really critical to make sure the strategies are matching the context in which we are working. So the R33 itself, as I said, is a stepped wedge where we'll be looking at HIV testing, including self-testing and access to self-test kits, which we will be distributing. We'll be looking at access to the knowledge of HIV, what are the linkages to biomedical strategies for HIV, as well as for substance use disorder, as well as access to overdose education. Our sample will be 1,200 people in the clustered randomized trial in 3 steps, and we will be looking at equity in the way we're engaging both sex, gender, sexual orientation, race, and ethnicity as part of looking at effectiveness. We are informed by the prison re-aim framework with a focus on equity in our model for implementation. And again, as I said, we'll be looking at costs according to the intervention, both the implementation strategies as well as our clinical EBPs. This looks like a very busy framework. As many of you know this framework and have used it, we will be looking at the internal context, which is, of course, the jail setting, organizational issues, staffing issues. We will also be looking at external issues around policy, funding issues that may facilitate or be barriers, as well as county level issues that facilitate or inhibit the coordinated care for people who are detained in a particular jail or who will be transitioning into the community. We'll be looking at reach, effectiveness, and adoption of both the implementation strategies as well as the clinical outcomes as well, with specific questions around equity. Again, hybrid type 2 can be so complex, as our team keeps talking about, right? So we're looking at both the mediators of implementation, but also those mediators and outcomes of effectiveness. Our strategies on the left-hand side, I'll go into a little more detail around a data-driven approach of a community coalition work group, integrating HIV with substance use disorder, tech-mediated service delivery in jails using telehealth to both screen, assess, and link people to care, an implementation team with a trained champion within the jail facility, but also including community members to make sure they're preparing for reentry, external facilitation provided by our team, as well as other technical providers such as the Opioid Response Network, and then tech-mediated training, which is around prioritizing stigma and harm reduction, intersexual stigma, which is really critical to address as we engage people at risk for HIV and substance use disorder. Those trainings will be offered to our staff and administrators who are implementing TechMPower, and then we will see the uptake actually of that training on things like HIV testing and even knowledge of HIV self-testing, as we have agreement from the facility to offer self-test kits upon release voluntarily, as well as Narcan or naloxone kits related to overdose prevention at release as well. So I said earlier, we're building on the workflow that has been developed for medication for opioid use disorder. We've been able to integrate HIV into this so that it is more efficient. We're empowering people who are detained around knowledge of HIV testing. We're hoping that we can, through the training and strategies that we build in retention and efficiency, because we hear constantly that workload is challenging, as well as the lack of staffing in these facilities is a real challenge, especially when prioritizing safety over healthcare at times. So we're hoping to make and introduce, and they discover and own new efficient ways of doing this work using telehealth, using in-reach from staff from the community as well. This is our pilot team with our champion sheriff, who's quite amazing in this particular community. You saw the Oracle team earlier, and you see this particular facility that actually has a harm reduction vendor machine that we've placed out there right outside of the front door there. So launching this study can be quite complicated as researchers enter a context like this, which is quite hierarchical, making sure that you're engaging the decision makers, you're referencing that hierarchy, but also that you're being very clear about what you're introducing to the site. That it can be quite confusing about what the research is asking, making sure that our language is clear and not too researchy is one of the lessons learned that we hear, and that we have to adapt, of course, to the language of the people that we're engaging as administrators. Really critical to have a champion who's on the inside to help facilitate a lot of the barriers around privacy, confidentiality, and safety. This is the pilot trial, again, in one site, beginning with the mapping, but you'll see on the upper is the implementation strategies, which will follow a baseline from those who were recruited from staff as well as from participants. The strategies will begin, and then we'll do follow-ups at 2 months, 3 months, and then we'll be observing the clinical outcomes from those who have been consented to participate, who did provide HIPAA release forms. We'll be extracting some data from medical records as well from the facility itself, or once they have left the facility in community level providers. So in this particular hybrid type 2 who are not familiar, which is really equal shares of looking at implementation with effectiveness, clinical outcomes. And as you see here, again, a reminder of our clinical outcomes around HIV testing, status knowledge, antiretrovirals and PrEP, SUD screening, as well as MOUD initiation and maintenance. The implementation metrics that I mentioned earlier, informed by REAIM, these are provided through administrative data as well as process level data. And the mixed method, as I said earlier, includes also medical chart extraction. For the step wedge, which again can be, why do we use a step wedge? Some would call it because of ethical reasons, because everyone will get the intervention eventually when it comes to the site specifically, but not everyone who's actually recruited will get the same dose of intervention. But it's much more about logistics and resources. When you roll this out, again, we'll be rolling 2 sites at a time with 6-month measurement periods, and the final period in which we will allow all sites to be fully implemented for 6 months to give us then time for analysis in the final part of the phase. The actual recruitment strategy is an open dynamic cohort, meaning that people can be recruited at each of those time points ongoing. So, and then will be followed up with specific measures, as you saw, particularly, right? So, again, why use this particular intervention, and things that to be watch out for, certain intervention bias that may be incurred because the transition from pre-intervention to active intervention and then post-intervention can be blurred. So again, our statisticians will be working very carefully to capture that transition period, those temporal issues that come up in the model. So what is the criteria for engagement for our longitudinal cohort? They have to be 18 and older, English speaking for now. We will be looking at translation of Spanish for maybe the full trial, but also are you likely to be released in the next 3 months? Because we wanted to capture as people were transitioning into the community with the linkage to care. Again, are they using some illicit or illegal drugs or prescription medication not as prescribed in the last 6 months prior to incarceration or in drug treatment, and some HIV risk, condomless sex, or sharing drug injection equipment prior to incarceration. The evidence-based practices I mentioned earlier again, HIV self-screening, self-testing, informed by WHO guidelines, as well as TRUST, which is a partnership self-testing protocol that one of Dr. Fry has introduced, evidence-based practice. And then we have ESPERT, which is going to be enhanced with screening for both opioids as well as stimulants, and then also enhanced with the telehealth engagement, that screening and assessment to make sure that community providers are engaged in those early intake processes. So if they are on medication already, they can stay on medication rather than going through a withdrawal protocol. And then finally, we will have a peer navigation enhanced case management component with a community provider that will do in-reach into the facility, either in person or through telehealth. And that particular provider will provide ongoing support 6 months following to link people to both substance use care as well as the HIV care and prevention. This is a little more detail about our self-testing approach. We're very excited that our pilot site has agreed to do universal opt-out testing and to allow for the self-testing to be offered as part of reentry planning. We also are going to be introducing a web-based EDOVO program that anyone in a site can listen to as part of their educational training, and they can receive incentives for doing that. This will be provided by a peer reentry specialist in this, but also our nurses in the facility will be trained to offer the self-testing education. When it comes to screening, the thing to note here is that, again, we're going to have facilities understand what are the available screening tools available, the newest available. They may have some in existence now. We will watch as they examine their protocols and whether they enhance their screening tools or the way they introduce the screening through, for example, motivational interviewing principles from the training that we will provide. We will also make sure that each facility is doing overdose education training, and we will provide and support them in offering that kit upon release. This particular navigation case management enhanced approach, our partner coming out of San Francisco, and it is an evidence-based practice adopted by the CDC. It is a neutral status approach. We will be tailoring it for that. So it's not just people linked to care who are living with HIV, but also at risk for HIV. The training of this navigator case manager role, we're understanding whether it's 2 people or 1 person combined. The training component, the hiring component is going to be very critical there, especially enhancing their knowledge of the criminal legal system, HIV in general, harm reduction, and then ways to enhance their work through a telehealth practice. Our implementation strategies, particularly, as you saw earlier, this data-driven, equity-focused approach, we have already begun to build on the coalitions from the Healing Community Study. They've agreed to do a subgroup in which they will combine substance use disorder with HIV and criminal legal together. A champion from the jail will help facilitate that within the community. It will be on a Zoom, primarily Zoom, so to be more efficient. The implementation team will build on reentry planning already, but more of a care coordination approach. We're seeing a lot of siloing within facilities between reentry planning and medical care. Often they don't know who's on medication or not. And even as they're planning reentry, that knowledge is often not shared. So we're hoping this particular team can integrate that approach, especially as they're introducing prevention strategies as well, which will be quite novel. We will be available to co-facilitate meetings with them as their internal if facilitators own and adopt and feel confident in the approach that has been introduced this through ongoing coaching and technical assistance as needed, as well as training being offered, and CEUs, which is often an incentive for staff to be engaged in training. So really some early lessons learned so far. I cannot stress more the importance to leave time for IRB approval in the process. When you're doing a study with people who are detained, it is required by DHHS to have a prisoner advocate involved in the IRB. There is a prisoner checklist that must be signed off of and presented orally to the IRB in order to approve the protocol. And reading comprehension is really critical. So we had to target an 8th grade level. We had to show how we did that. And just to be frank, we submitted 3 times as we make sure we responded well to the IRB feedback. And just now we're on the edge of that approval with only one more comment to be approved. So we're very excited to be able to launch fully in December. There is a secondary level of review by the Office of Human Research Protections as well as part of a study that is with people who detained. We can't stress also the importance of a state CAB. We saw it already. We've developed and launched it in that we make sure we include people with lived and living experience, their perspectives, especially those communities that are highly stigmatized or excluded often from these conversations. It is really critical to look at sustainability as well as problem solving around things like funding, policy issues. Again, we're already in the mode of advocating, for example, on ways that HIV test kits can be paid for at the state level. Again, really critical to prepare for the carceral culture, which is very hierarchical, to know who to talk to first, to get permission to talk to the next person, to build a particular champion who is on the inside, who's to help us navigate the issues around safety, but most importantly for surveying, the use of internet access and digital surveys. This is really quite an important point, knowing that we all know that these surveys around sensitive information, having a digital survey available is really important. Paper-based can sometimes double the time it takes to do a survey. We will have that as a backup. We're learning a lot from our partners in other jails who have implemented digital surveys. Special software is used to limit the survey access to the internet to, for example, only one link, and that is the one way to get that approved. We're also seeing that there are iPads within facilities that could be utilized as long as they have been pre-approved by the administrators. So there are lots of technical aspects to be incorporated, but also building on the other educational opportunities within the facility. For example, there are training rooms, there are counseling rooms where the surveying can be conducted in a secure way while being observed, which is required while you're actually on a pod within a facility. Confidentiality cannot be stressed more when it comes to IRB approvals of 42 CFR Part 2. The language has to be very carefully included in the consent forms, and it is part of the prisoner checklist that if it is not included, it will be turned back to the researchers. That includes, by the way, making sure that people who are detained know that they will not get special treatment from their parole board, probation, or court-mandated orders for participating in research. Also, the other aspect was making sure we're clear about how we're providing and linking people to mental health services should they be uncomfortable, either during the surveying or participation in the study, making sure the urgent care is available, but also ongoing support provided, whether within the facility or in the community as well. And then finally, protocols and memorandum of understanding, MOUs, can take time as you develop them with your community partners. In this particular study, making sure we have distinct agreements with correctional health, which might be a provider that is subcontracted by the county, or it may be directly hired by the county. So you've got to be adaptive when it comes to this. And again, supervisory roles and permission roles are really critical to follow. So, for example, the CEO for the correctional health facility must sign off first in collaboration and in conjunction with the jail administrator or sheriff in that process. Having a distinct scope of work with the administration, really critical to spell out safety, access, and also that we would agree to participate in safety training and orientation in order to be allowed into the facility. As far as a community-based approach, permissions from your local county Department of Health on mental hygiene to partner with your coalition is what we're also building in. That requires legal review at the county level, so that can also take time. And finally, when it comes to costing, really critical to consider what are some sustained approach to staffing this type of intervention. For example, we're learning around the peer navigator ways to have billable services being offered, and possibly the research study pays part of that staffing, and the other billable access covers the other part of the staffing. So that really helps for the feasibility of the study as well as ongoing sustainability. So I've done a lot of talking, and I'm hoping maybe there's some important questions that do come up, and we can answer them together. I did want to point to some additional resources that you might take a look at here, which combine both our HEAL work as well as our work with the criminal legal system. Check this out, this webinar and resource that we have on our website at the Social Intervention Group, as well as additional resources when it comes to HEAL and our work with community engagement.
Excellent. Thank you so much.